So in this session, we are discussing the treatment of pre-existing coronary artery disease prior to TAVI procedures and avoiding coronary artery obstruction during the procedure. So Jonathan, TAVI operators to me seem to broadly fit into one of three categories in terms of treating pre-existing coronary artery disease, either aggressive interventionists or don't do anything unless you really have to. And then there's sort of an intermediate pragmatic group. Where do you stand?
I think that's a fair summary of where people sit. There's practice which very aggressively treats coronary disease before TAVI, fully revascularises the patients. From my point of view, it's slightly more nuanced. If the patient presents with angina and has significant coronary disease, we would tend to revascularise them first before the TAVI. In the patients with significant coronary disease without angina, we tend not to treat the coronary disease and treat the valve. And I have to say that we don't quite know which of those is the right answer, which is why I suspect there's a group in the middle that will revascularise proximal coronary disease before a TAVI in the absence of angina. And it's an important area. There is a randomized trial which is running now, which we're involved with, where we're randomising patients to PCI prior to TAVI in the absence of angina, or no PCI. And my suspicion is there will be little difference between the groups. One thing that's worth pointing out, though, is that if you are coming back to a patient who has a TAVI valve in situ and you then need to treat their coronary disease, it can be extremely difficult. And I've had a number of these cases where they're elderly patients with calcific coronary disease, and achieving adequate support and getting equipment down the vessels is difficult. So there is a balance to be struck between revascularising these patients and leaving them alone.
So you're saying in the absence of angina there would be a tendency to do nothing, but presumably there are some patients who you just feel you have to...
I mean, left main disease is one area where most of us would revascularise first. So important left main disease or left main equivalent, I would treat percutaneously before, in the absence of angina, before proceeding with a TAVI. And the rationale for that is it's such an important proximal area that it might induce hemodynamic instability during the procedure, from which you may not recover if you haven't revascularised the area. So that's the group I would tend to treat. There is another smaller cohort of patients who you're concerned about the osteal disease in the right and the low-lying coronary that you might want to treat for technical reasons so that you could proceed with a TAVI. But in general, asymptomatic patients with coronary disease, I leave.
Okay. Lars?
We treat all patients who have a significant stenosis prior to the procedure. If we in doubt, we'll do FFR measurements. If they have a significant proximal stenosis, it's going to be revascularized. First of all, because it can, as you say, Jonathan, can cause problem during the procedure if the patient is running a low blood pressure. Also, at least if you implant a core valve, it can be very difficult to go back and treat it later on. And also, I think there's symptoms, even if the patient don't have any angina, he's short of breath, and that could be symptoms on the same disease. You can't say, even though he don't have complaint of angina, he only have shortness of breath, it could be a symptom from the coronaries. So we will treat all significant proximal lesions prior to TAVI.
Okay.
We have the same approach. If there is a significant lesion, it's treated before the TAVI.
Different approach, as usual. So the pathophysiology is a problem. We have to take into account that the patient with an aortic stenosis has an increased afterload, increased end diastole pressure, increased thickness of the wall thickness. And so if the patient with all these conditions is asymptomatic, that means that the narrowing is not impairing the coronary flow. And so we don't treat. And we did a retrospective analysis in a huge registry in Italy, but there are 2 or 3 registries. Most of the registries say that the treating or not treating coronary artery disease in stable patient doesn't change the prognosis of the patients. So we try to avoid to treat the patient. And in doubtful cases, we do perform the balloon valvuloplasty, and then we treat the patient in the coronaries of the patient. And after 1 month, we send the patient for the TAVI.
But Corrado, can I ask you, or also you, Enrico, if the patient went for surgery, what would the surgeon do?
Okay, we did also in observant registry the bypass surgery plus aortic valve replacement increases the risk of mortality in the patients as well as the risk of stroke. But it's a different condition. With a beating heart, we are treating a patient with a normal coronary flow. During the surgery, the coronary flow is interrupted, so it's a different issue. So restarting again is a fully different clinical condition.
But wouldn't your
surgery
surgeon
is
treat a significant proximal stenosis
Yeah,
when he did the
he has
aortic
to
valve
treat.
replacement?
He has to
Absolutely.
treat.
Yes,
He has to treat.
we do that.
He has to treat the surgery. During surgery, must be treated any coronary lesion.
Exactly.
During percutaneous intervention, no.
I agree with Corrado. I think that, we have taken many patients with unrevascularized significant coronary disease, left main excluded, through transapical transfemoral procedures, rapid pacing, and they tolerate it perfectly well. It's not true that the majority of cases are intolerant of that hemodynamic insult. The caveat for me is important left main disease, and that's the only one that we revascularize in general. But I think there are different population from the surgical population that go into bypass.
Completely different population. But you were right when you said that if you have to perform the... Yeah, exactly.
Is there actually any data in cardiac surgery to tell us that grafting vessels in people where the predominant problem is a valve, grafting vessels improves outcome?
Well, yeah, there are some results in the past, and that's why we know that right now that we have to do coronary surgery together with vascular surgery when you have critical lesions. If you don't do that, probably the results are worse, and of course you should do something later. So what we do now, what is the gold standard, is if you have to change the valve with standard surgery and you have critical lesions, we have to do bypass as well.
But often in TAVI, we're not necessarily talking about critical lesions.
It's
There's a
different.
difference between significant
Exactly.
and critical, isn't there?
Yeah, exactly. But the problem is that in standard cardiac surgery, you have another assess. It's completely different. We stop the heart, we do cardioplegia, so it's another situation, it's another completely different patient.
The coronary artery disease in such patient is a benign phenomenon. It's a stable angina or stable coronary artery disease. So why should you treat a lesion that took 80 years to become 85% or 80%? It will take, percutaneously I'm speaking, it will take 10 more years to becoming severe or occlusive.
I mean, there are obviously these concerns about rapid pacing. I have to say we're perhaps closer to Lars's viewpoint than Jonathan's. Anyway, there's obviously a lot of variety there.
It's good that there's no right answer.
Well, exactly.
We'll have discussion
Exactly.
otherwise.
But I mean, as you're doing here in the UK, a randomized trial will be very useful to see how to approach this, because it's there's no evidence.
We don't know.
Yeah.
We don't so far.
Okay, so Corrado, obstruction of coronary ostia during valve deployment, obviously potentially catastrophic. I was at a meeting recently where someone was presenting a case of a patient where the distance between the coronary ostia and the annulus was 8 millimeters, and the presenter asked the panel, how would you deal with this? And the first guy said, well, I would always use a core valve in this situation. And the second chap said, I would always use an Edwards in this situation. And the third chap said, why are you measuring the distance between the annulus and the coronary ostia? So there's no consensus there. How do you treat it?
So when we have a low coronary ostia takeoff, we cannulate the coronary with a wire by radial access, and so we put in security the coronary artery, and we try to use an Edwards valve so we can cannulate the artery easier than with the Corrado valve. But the truth is that we have to take care about the takeoff, but also the depth and the width of the coronary sinuses, which is important too. So what we do is what I said. So we prevent the coronary obstruction, or we are able to manage the coronary obstruction just after. Another point is that in these cases, the balloon valvuloplasty gives you an idea, because if you inject dye during balloon valvuloplasty, you see where the calcium spurs or the valves go, and you can predict also if implanting a valve you can have a coronary obstruction or not.
Has anyone been falsely reassured by that? So they've done the balloon valvuloplasty, injected, so looks fine, then they put the valve in and had coronary artery obstruction.
I haven't seen any.
We've aborted a case.
Sure.
For the precise
for that reason, absolutely.
And Corrado's point's well made. It's the size of the sinuses that are the key. So a low-lying coronary ostia with reasonably sized sinuses will often take the valve leaflet below it. But if they're small sinuses and a bulky leaflet, that's when that's the worry. And we've done a similar procedure to Corrado. We will often wire with a guide and a balloon the coronary that's threatened, but we haven't had to treat it as yet.
How would you define low-lying? Is that subjective or objective?
Well, you can measure it. Criteria said to be less than 11 millimetres to the left main. I think 14 for an Edwards. But between 10 and 14, you're in that borderline area that you'd have to assess carefully with the balloon valvuloplasty. We often worry about the right more than the left main. That's often slightly lower lying. But they're the sort of borderline figures that we worry about if we have that sort of distance.
And what sort of proportion are you wiring the coronary arteries then?
A small proportion. So
Very
I think
small.
it's probably a handful of cases a year that we would have to wire one of the coronaries.
Yeah.
Okay. Lars, Enrico?
Yeah, very few.
We never do it, but we're also using the core valve. I don't think it'll make any sense to wire it, because the wire will be jailed between the ascending aorta and the frame.
We did a case with after coronary valve, the right coronary artery was occluded, and we used the wires for chronic total occlusion for rewiring the coronary artery, and crossing was successful, but it took 45 minutes.
But what we sometimes do, if we are concerned, is that we always have a snare in the room, so we can, with the core valve, go in, get the eyelid, pull it out. So we haven't used it so far, but
The only problem we've had with coronary arteries is clot flying into it. We've never had a coronary artery obstruction due to the valve. The randomized trial. Do you want to summarise that?
So the randomized trial is taking patients with coronary disease and significant aortic stenosis without angina, so important epicardial coronary disease in one or two vessels, and randomizing them to PCI with a bare metal stent or bare metal stents prior to TAVI, which would happen, within 6 weeks of that procedure. So they would come off one of their antiplatelet agents at 4 weeks or a month.
Why bare metal stents and not DES?
Because the rationale is that they should have their TAVI procedure relatively quickly after the PCI, and if you're using dual antiplatelet therapy, it doesn't preclude, but it almost certainly precludes most surgeons doing a transapical approach. So we are split still, certainly within our centre, about 70-30, perhaps 80-20 transfemoral, transapical. So drug-eluting stents would preclude the surgeons doing a transapical procedure.
And how many in each arm?
So it's offhand, I don't have the figures in front of me, but I think it's around 250 in each arm, 250 to 300.
And how's recruitment going, do you know?
It's going. I mean, there are plenty of patients with coronary disease and aortic stenosis, so finding the patients isn't difficult. But I think recruitment has been slow. I mean, there are, like all randomized trials, there are people with very fixed ideas of what should be done in many patients, particularly this group of patients. So that has been a stumbling block, but it will recruit. It's really only started over the last 3 or 4 months.
So Jonathan, what's the end point of the study.
So it's procedural success. So the safety during the procedure, whether there's any difference between the revascularized, non-revascularized in terms of procedural outcome, and MACE at 1 year. So it's standard, and I suspect it's powered to, the event rate's going to be relatively high because of the population we're studying, which is why the numbers are relatively speaking small.
Yeah, absolutely. What proportion of patients are you saying the coronaries are too low, we can't do a TAVI?
In a native aortic annulus, we haven't declined anyone with the core valve, and again, we haven't seen any coronary obstruction. And just going back to the post-market study for the Medtronic core valve with 1,000 patients, there was one episode of coronary occlusion. So I mean, it's not a big issue with the core valve. So I haven't declined anyone. I mean, if you move into the valve procedure, that's for certain some of the valves you have to assess very carefully. But that's a different story.
Enrico?
Yeah, we do mostly Edwards valve, but during the last 3 years, I don't remember a case that was cancelled due to the fact that the coronary were too low.
Okay. We had our first patient today we cancelled.
All right.
Yeah, absolutely. Bicuspid valve, very low coronary artery, so we cancelled. Okay. The last agenda item was how does one treat coronary artery obstruction? I guess the answer to that is quickly, so we can draw this little session to an end. I think we still remain concerned about coronary artery obstruction during TAVI procedures, but in fact there's very little data, and what data there is perhaps suggests that we're more concerned than we should be about coronary artery obstruction. In terms of treating pre-existing coronary artery disease, again, there's little data. There's a very varied approach, in fact, opposite approaches, but there is a randomized control trial which hopefully will shed some light on this area. Okay, thank you.